Last but not least, we have Dr. Maria Joan LOY, and she's going to talk about management of malignant glaucoma.
Good afternoon, everyone. I'd like to thank APVRS for allowing me to speak this afternoon. So I'm tasked to talk about, this is not my, no, not that one, malignant glaucoma. I'm tasked to talk about management of malignant glaucoma. Okay, so malignant glaucoma has been called several names, including aqueous misdirection, ciliary body block, among others. It is due to an abnormal relationship between the ciliary body, the lens, and the anterior vitreous. So the exact mechanism is still unclear, but it can be multifactorial. So one theory is that the misdirected aqueous behind the anterior hyaloid, lens, and the zonules, they are unable to reach the anterior chamber, causing an increase in the volume and pressure behind the lens, pushing forward the lens, the iris diaphragm, and the ciliary body, causing a pupillary block and increase in pressure in most cases. So it occurs in around 2% of glaucoma surgeries. Risk factors include short axial length, shallow anterior chamber. Both are characteristics of female eyes, no? And it is also increased in patients with aqueous misdirection in the other eye. Reports of malignant glaucoma after laser iridotomy, cataract surgery, and even the use of myotic drops because of the relaxation of the zonules, then this anterior displacement of the lens. So symptoms in early signs, no? Patient may have a myopic shift, no? They can read better at near because of the anterior displacement of the lens. Patient may have blurred vision, eye redness, and eye pain. Signs include shallow or flat anterior chamber because of the anterior displacement of the lens iris diaphragm and the anterior hyaloid face. They may have elevated IOP, but they may also have normal eye pressure, especially in patients post-glaucoma surgery. In making a diagnosis of malignant glaucoma, it is important to consider angle closure from pupillary block, especially in patients with flat or shallow anterior chamber and elevated IOP. No? But unlike your malignant glaucoma, wherein you have a flat anterior chamber uniformly, including the central part, with your pupillary block, most of the time there's iris bombay, flat or shallow peripheral anterior chamber, but reasonably there's a space, no, centrally. So what you can do, what can differentiate the two is your peripheral iridotomy or iridectomy. So if you have a patent peripheral iridotomy or iridectomy, but still with very flat chamber, most likely it's malignant glaucoma. Your diagnostic imaging plays very important role. In patients with very hazy media, you can do ultrasound to rule out other causes of flat or shallow chamber like your choroidal detachment. Your ultrasound biomicroscopy or anterior segment OCT will be very helpful in assessing the orientation of your angle, the iris, and the lens and the ciliary body. So management involves a multifaceted approach. In patients post-ocular surgery, you need to consider check for wound leaks, and then in patients post-glaucoma surgery, you need to also check for overfiltration. If you have a flat chamber and then you did already a laser iridotomy, it's still flat. If in doubt about the patency of the iridotomy, you can do another iridotomy just to be sure. Once it's established that your patient has malignant glaucoma, medical management can be started. Okay, so the treatment focuses on eliminating pressure differences within the eye, aiming to reduce the aqueous humor production, shrink your vitreous, and then improve the aqueous flow inside the eye. So while 50% of cases respond to medical therapy, there's a high chance of recurrence. No? So your laser treatment aims to release the aqueous trapped behind your anterior hyaloid. So sometimes even with your medical therapy and laser therapy, recurrence rates, they're high. That's why surgical treatment may still be needed. So for the surgical management, the aim is to restore communication between the anterior and the posterior segments. So techniques like anterior vitrectomy combined with iridectomy, zonulectomy, and hyaloidectomy, it's an option. But studies have shown that if you do complete pars plana vitrectomy, iridectomy, zonulectomy, hyaloidectomy, and capsulectomy, they give the best results. So don't forget to manage also the contralateral eye. So prophylactic measures should also be done in managing the other eye as well. So sharing with you some cases, okay, from my glaucoma colleagues. Okay, so this is a case of a patient post-trabeculectomy with patent peripheral iridectomy. A few days after the malignant glaucoma event, the chamber was formed, status post vitreous tap and air bubble injection. So this is a case presented by my colleague who's also here, Dr. Tumbokan. He presented this case in APGC in 2021. I co-managed this case with him. This is a case managed with irido-zonulo-hyaloido capsulectomy and vitrectomy through anterior approach. So it's an option especially by anterior segment surgeons because they say direct visualization of your instruments, it's better compared to the blind approach via the pars plana. So patient is a 65-year-old male post-cataract surgery who had malignant glaucoma treated medically combined with laser iridotomy, capsulotomy, hyaloidotomy. But in spite of all those treatment modalities, the vision remained light perception and the IOP remained high. The anterior chamber was flat with posterior synechia. On UBM, the ciliary body was anteriorly rotated with a displaced PCIOL and iris diaphragm. The ultrasound was unremarkable, so there were no signs of choroidal detachment. So we did a stab incision through the cornea, iris, lens, capsule peripheral to the PCIOL, and then up to the anterior hyaloid face. Egress of fluid was noted, and then the eye softened after the escape of fluid through the opening. And then a vitrectomy probe was used to, So viscoelastic was used. After we softened the eye, there was a permanent corneal iris adhesion. So we used viscoelastic to break that adhesion. Sorry, the video's not working, I think. Hold on. Okay, so we injected viscoelastic to reform the anterior chamber. We injected also into the area of the angles to attempt to reopen them. And then we used a vitrectomy probe to remove the membrane and to open up the synechia. And then we also used the vitrector to enlarge the pupil. After that, the vitrectomy probe was used for peripheral iridectomy, zonulectomy, and then additional pupilloplasty. We use the infusion cannula as the anterior chamber maintainer. And then the vitrectomy probe was further used for zonulectomy, capsulectomy, and then anterior vitrectomy. So because of the presence of 360-degree peripheral CNK, AMED valve was placed. So the vision of the patient improved to 20/50 with good IOP control. So this is another case of malignant glaucoma status post-AMED valve implantation managed with complete pars plana vitrectomy and then capsulectomy, iridectomy, and zonulectomy. So in summary, malignant glaucoma is a serious condition that can lead to irreversible vision loss if not managed promptly. While medical and laser treatments can be effective, they may only provide temporary relief. Complete pars plana vitrectomy combined with iridozonulocapsulectomy appears to yield the best long-term results. Thank you so much and hope to see everyone in Manila for APVRS 2025 this coming December 12 to 14. Thank you.
Thank you very much. Any question from the floor?
I wanted to ask Manisha ma'am, how do you decide where you will do scleral cut down by B-scan guided?
Could you repeat your question, please?
Ma'am, how do you decide where you will do scleral cut down for draining the suprachoroidal hemorrhage?
So as I mentioned, when you're doing the ultrasound, wherever you are having the maximum amount of bulge, the maximum height of the choroid, I think I would choose that particular quadrant to do the scleral cut down.
And also, Sangeet sir, so your technique of putting the haptics during SFIL in the Geber-Shere tunnel using the cut needle, can you elaborate?
Sorry. So what we have seen is like when we make a pocket with a needle and we try to insert the haptics inside the pockets, the haptics generally get damaged sometimes and the whole thing is lost. So what I do is like I break the 26 gauge needle from the middle and I just insert the middle instead of making a pocket. And I just put the haptic into the lumen of the needle and bring the needle out from the other side. The haptic remains in place while the needle comes out. So that gives you a snugly fit haptic inside the sclera. That is, no, it was the same 26 gauge needle. So one point I'd like to make here about this was like, earlier I used to do a partial vitrectomy with removal of the capsule and for these malignant glaucoma cases. But the rate of recurrence or the rate of failure was quite high. So then I switched to complete vitrectomy. And I think I found a very good alternative to this. So if we are planning to do a vitrectomy, then I don't think there's any rule we should stop at just a partial vitrectomy. Just do a complete vitrectomy and get a better results rather than. So what is your view on that?
I agree, but sometimes because of the elevated pressure, you have very poor visualization of the posterior segment. That is why sometimes you're forced to do anterior vitrectomy via the anterior approach. But based on studies, it's best to do complete PPV.
And another thing that you also mentioned was like formation of the anterior chamber is also very important during that part, because if you let it remain so, the things won't get better. Thank you.
I've got a question regarding the timing of going in. Often a surgeon will be asked to become involved. What do you tell our glaucoma colleagues about when a VR consultation should take place?
Okay, I think the sooner you intervene, the better, especially if the eye pressure cannot be managed medically, even with maximum medications, to avoid, if you wait longer, you'll have the other complications like corneal problems, and then you'll have your permanent adhesions.
Yeah, I found that sometimes the glaucoma colleagues will wait a little bit because it seems to get a little bit better, then a little bit worse, and a little bit better, a little bit worse. And this goes on for about 10 days. And then on Friday afternoon, you're called.
Yeah, or just right before you're leaving for a convention or a vacation.
It's just like when you are about to be doing something on the macula, that's the time patient decides to move. I've never been able to really find a very good answer to that. Dr. Andrew, I wanted to ask you one thing, that have you changed your first line of antibiotics over the years because of antibiotic resistance?
That's a very good point. We haven't changed our intravitreal choice of drugs, so it's still ceftazidime and vancomycin. But we have evolved in our topical drops, but not intravitreal. We don't have any strong evidence at this stage. But in the treatment of endophthalmitis, I think it was mentioned by you that microbiologic diagnosis is really what we need. We can go in and do empirical treatment, but once we have a diagnosis and we know our resistance and whether we're dealing with a fungus or some other unusual bacteria, I think then we can potentially win the war, as you used.
Regarding malignant glaucoma, I am a glaucoma expert. So normally what we do is we take a vitreous cutter and go from the anterior side through the PI. You cut the iris, or if there is a PI, you do the get through that PI, cut the hyalidocapsular adhesions. Until unless you cut that hyalidocapsular adhesion, there won't be any single chamber, and that aqueous which is there in the pocket, it will be released. So rather than doing a whole sort of a big vitrectomy, it is better you do the hyalidocapsular adhesion which are there and release it and make a single chamber between the anterior and the posterior.
Can I just ask, that procedure that you just mentioned, is that done, can you do that in the office or on as an outpatient, or do you take the patient to an operating room?
No, it has to be in the theater with all the precautions. But only thing is, like, you have to go from the anterior rather than doing a posterior vitrectomy. And being an anterior segment surgeon or glaucoma surgeon, you don't require a vitreous surgeon to do it, or the posterior segment surgeon. So you go through that PI. If it is not working, it will start working. And if there is not in the zone where you are comfortable doing the further vitrectomy and release, you can create one more hole in the iris and go through that.
Yes. Okay, very good.
Thank you.
So I had one comment regarding the usage of intravitreal antibiotics. The usage of piperacillin tazobactam here is quite, I have seen good efficacy as a broad spectrum. And one question to Manisha ma'am was regarding mention of being aggressive in fungal end-off and injecting every 24 hours. So what about the use of systemic antifungals? Do you advocate equally aggressively, or what would you suggest?
So if I could hear it properly, you've shifted to piperacillin and tazobactam as the first line, right?
That was, yes, for bacterial, in addition to vancomycin also. So that was just
Right.
my suggestion.
That's exactly what I was asking, Dr. Andrew, that have they also changed the antibiotics? But I think, as you rightly mentioned, of course, the choice of antibiotics would depend upon your microbiome report, and that is going to be the best guide of what antibiotics to use. Empirically, initially when you are taking up the patient, when you don't have any report in the hand, yes, we all give some antibiotic empirically at that time.
And in fungal cases, would you advise systemic antifungals?
Yes, of course. Yes. So we have to get a kidney function test done, and a liver function as well. And yes, then you have to keep them on quite a long-term systemic antifungals.
So in acute infectious like bacterial endophthalmitis, any role of systemic antibiotics, or all of you still give systemic antibiotics?
The role of systemic antibiotics for endophthalmitis.
Sorry, I don't think we have any established evidence for systemic antibiotics, but we still give, oral anyway, but we don't have that at this stage.
So what's your antibiotic of choice? What you give? And what Manisha ma'am give?
Usually I would use ciprofloxacin. Yeah.
Yeah, we all do that.
Oral?
Yeah, quinolones, they have the best, especially the third generation, they have the best intraocular concentration. So that's what we give, because it's very devastating to have endophthalmitis, so it's better than not giving it. Of course, some people may argue about that.
Thank you.
When you take the sample to send it to microbiology, do you like to, a lot of people say before you switch on the infusion, you try to do a dry vitrectomy and send that undiluted sample, more chances of getting an organism instead of switch on the infusion and you get a diluted sample. Any experience on that, sir?
Usually we try and give two samples. We give an undiluted sample, and we can take that directly. And also we can do an anterior chamber tap as well. And I think increasingly, when you are not certain of the diagnosis, you can actually give the washings. But we generally do not do that, just an undiluted, maybe 1 ml.
Also, when we are trying to collect the undiluted sample, if you start having a hypotony, it's a good idea sometimes you can connect your infusion with air. And that's not going to dilute the sample, and you can collect an undiluted sample.